So T3, T4 are low, but TSH is normal. That means nothing is happening to bring back the thyroid levels to normal. Primary hypothyroidism means your thyroid is not well. So your thyroid is not working. So imagine if my thyroid is not working, that means no thyroxine. This is because they were consuming thyroid, right? And it takes time for the blood levels to clear out. But it is not enough to maintain the metabolism. So the TSH becomes high. Welcome dear doctors. Today we are at the second lecture of endocrinology and we are going to do thyroid, parathyroid and the related syndromes. Okay, so we are going to start with a very important topic, sick euthyroid syndrome. So basically it presents in a chronic illness and here the thyroid profile is a bit abnormal. They say that everything is low, but actually in the majority of the cases the TSH is not low, TSH is normal for the rest of the things. So let us look at the notes here. So they are also naming it non-thyroidal illness. Non-thyroidal illness means that the illness is not related to thyroid, okay? But when we do the bloods of this chronically ill patient, we get abnormal thyroid profile. But when we look at the TSH is inappropriately normal, okay? Now this presents with a low thyroxine and T3. So T3, T4 are low, but TSH is normal. That means nothing is happening to bring back the thyroid levels to normal. Okay. Though it presents like this, we are not going to treat it. We are just going to follow it up because this is reversible. It presents with the illness and as the illness goes away, so does the abnormality in the thyroid profile. Here we have a question. Let me raise this. So I have already highlighted some parts for you. So 79-year-old woman admitted to hospital, presents to the emergency department with shortness of breath, cough and palpitation. So basically this woman is suffering from a case of pneumonia and she also has atrial fibrillation and some other things like fast ventricular response, and she was given IV antibiotics and fluids and everything you are giving, and then ultimately what happened is so the rest of the things are associated with the disease will straight away go to our labs, because what I want to show you is that so here the rest of the things look fairly normal, okay, and we go to the TSH, T3 and T4. So you see that they are within the normal range, but the TSH is also normal, a bit low, yes, 0.25. So let us see what they are going to ask us. So what is the most appropriate next investigation to assess the deranged thyroid function test? So they are talking about diagnosis. What do you want to do? Do you want to do thyroid peroxidase antibody levels? I don't think so, because it doesn't look like an autoimmune condition. Repeat TFT in 6 weeks. This looks promising because we know that this person is ill and now this person has presented with a metabolic derangement of the thyroid profile, and we are expecting that as the illness will go away, it will come back to normal. So we can repeat the TFT. So I think this is the answer. And let us see the other options: thyroid CT scanning and thyroid ultrasound, thyroglobulin antibody levels. None of these go with our question. So we are going to repeat the TFT. Okay, let's see. Now, thyroid function test. So before we go into the other illnesses, we have a chart. This is a very important high yield chart for MRCP, where they are showing you the different diagnoses and how you will match them to the TSH and free T4. Okay, so the first one is thyrotoxicosis. So before I go into the high and low TSH, let us understand a bit about the pathology of the disease. So thyrotoxicosis or Graves' disease is actually causing excessive secretion of thyroid hormones, excess thyroxine in the blood. So what should I expect? Lots of thyroxine roaming in the blood. So my thyroxine will be high, that is the free T4 is high, and as thyroxine will produce a negative feedback on the pituitary, it will cause the TSH to go down. So low TSH. If you remember the pathogenesis, it will be easier to correlate with the lab values. So here they are saying in T3 thyrotoxicosis, there is another variant, T3 thyrotoxic. So in that disease, T4 will be normal, but T3 will be high. Okay. Nevertheless, the TSH will be low. Okay. Then primary hypothyroidism. What does this mean? It is very important to understand primary and secondary and the other things. Primary hypothyroidism means your thyroid is not well. So your thyroid is not working. So imagine if my thyroid is not working, that means no thyroxine. So thyroxine will be low. So the pituitary will detect it and it will think, let me produce more TSH so that the thyroid can produce thyroxine. But the thyroid is not working. So even though the TSH becomes high, my T4 will be low. So in primary hypothyroidism or primary atrophic hypothyroidism, the TSH is high but the thyroxine is low. Then comes secondary hypothyroidism. Secondary hypothyroidism means the problem is not in the thyroid gland but in the pituitary gland, the one who is controlling the thyroid gland. So the pituitary cannot secrete enough TSH and as a result the thyroid cannot release thyroxine. So both of these are low. Okay. Then comes sick euthyroid syndrome, and we already stated that everything is low here, and basically it will be low and the history will give you an hospital or a seriously hospital inbound patient or a seriously ill patient, okay, with a very short history. Okay, then comes subclinical hypothyroidism. So what does this mean? Subclinical means he is not symptomatic, but they are also saying hypothyroidism, means they have something related to hypothyroidism. So I remember it in this way, that for the symptoms to develop, my thyroxine has to go down, right? But this is subclinical, no symptoms, so the thyroid is normal. But this is hypothyroidism, and in hypothyroidism we say that TSH is high, so the TSH will be high. So this is the combination that will tell you to choose subclinical hypothyroidism. Then some people who are regularly taking thyroxine for some sort of hypothyroidism and they don't take it continually, okay, they are giving gaps and then they have a blood test and then you get something like this, that the TSH is high showing hypothyroidism but the free T4 is normal. This is because they were consuming thyroid, right, and it takes time for the blood levels to clear out, but it is not enough to maintain the metabolism, so the TSH becomes high. So these two things, if you get both of this combination of high TSH and normal T4, think of these two things. Either it is subclinical hypothyroidism in a previously non-thyroid patient, non-hypothyroid patient, you think of subclinical hypothyroidism. And if you get the history that yeah, he is a diagnosed case of hypothyroidism, he was prescribed medication, that means either he is not taking it adequately or his dose is not adequate. In both the cases you will experience something like this. Then comes steroid therapy. So we give steroids for a lot of diseases, autoimmune diseases, then joint disorders and whatnot. So at that point also the TSH is low but the free thyroid is normal. Okay, so this is just a gist of all the diseases that come in the MRCP, and this is in one glance you can just revise. Okay, let us go with the next one.
Sorry for interruption.
Yes.
May I ask you a question?
Yes, please.
In case of secondary hypothyroidism, there is no replacement of steroid, right?
Yes, very good question, thank you. So they are saying that in secondary hypothyroidism means what? The pituitary is not working, right? Pituitary is not working, so sometimes there may be underlying steroid deficiency, that's why it is not working. So we start steroid and then we start the thyroxine. That means the problem is with the pituitary gland. Okay, that's why. So sometimes giving steroid before is better. They found in the studies that giving steroid before thyroxine helps the condition better.
So it is only sometimes, not always.
No, it is there. Yes, it is. Yes, we have to give steroid before thyroxine always.
Thank you.
Okay. Okay, am I going too fast? Since you are here, I can ask you. Is my speed okay? Speed off? Okay, thank you. Okay, so subclinical thyroidism, hypothyroidism, as I already said, that there is no symptom. As you can see here, there are no obvious symptoms, but we have an abnormal thyroid profile, means the TSH is raised, and I remember it in this way that T3 and T4, they will cause the symptoms. So they are normal, that's why this patient is asymptomatic, but his TSH is telling you that something is wrong with the thyroid. So what do we do with this patient? We are going to screen them again and again. We are going to test them regularly, because there's a 5% chance that this person will develop overt hypothyroidism. Okay, so we might test them for some antibodies, like whether any antibodies are there, whether it is an autoimmune condition causing the hypothyroidism, and also we are going to screen them. Okay, and when are we going to treat? So we are going to, we are going to treat if we get a very high TSH, 10 to 15, and if thyroid and autoantibodies are positive, if there is any other autoimmune condition. Okay, and if this patient is like giving you a history that, yeah, I was hyperthyroid, I was having Graves' disease in the beginning and now has presented with hypothyroidism, then you know that he will become hypothyroid soon. Okay, let us go to a question. So I have already marked the important points. So 65-year-old, see I have highlighted asymptomatic female, had the following thyroid function tests, and she was not taking any medication and enjoyed good health. So let us look at this. Here they have given you T4 and TSH. Okay, and the TSH looks, what does it look like? It looks high, right? Okay, and also the antithyroid myeloperoxidase is absent. So okay, let me ask you, will you treat this patient? Will you start treating this patient?
No.
No. Why? Because of the TSH level, right? And also the fact that
there is no risk factor such as antibody.
yes. May I get your name, sir? What should I call you, doctor?
Dr. Roman.
Dr. Roman. Okay, yes, very good, Dr. Roman. So do you want to start thyroxine? No, you said no. Do you want to reassure and no further follow-up required? Perform radioiodine scan, or you want no treatment but repeat the thyroid function test, or start the triiodothyronine? What do you want to do?
Notice that and repeat the thyroid function test.
Yes.
In this pass.
Yes, exactly. And we know why, right? Because we know that 5% will go on and develop hypothyroidism. Okay, there's another question. Let's see.